Yo, 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 what's going on YouTube? This your boy Steve Belcher with Urban Health Outreach Media. I'm about to do a live broadcast on anemia, how to control it to feel better. Well, I'm sorry, taking control to feel better. So I'm about to go live on our Be Live uh, broadcast so you can see me while I'm teaching this. This is awesome. Here we go. What's going on? Just keep paying attention. This is going to be a great show. Yo, 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 what's going on, Facebook? What's going on? Welcome to a special edition of Kidney Disease Education Moment. I am your host, Steve Belcher. So I'm broadcasting simultaneously. I have my YouTube going on right next to me, broadcasting live from there, and I'm broadcasting live from this platform of Be Live. So, wait a minute, I had a person that, let me see what she said. Uh, Let me see. Go to Urban Health Outreach Media page. So, yeah, guys, welcome. Hey, Jeremy, thanks for tuning in. Please share this. Please share this broadcast. This is going to be a great one. Up next at 8:30, we got the Warriors Quest with Jared Brown. So let's get started here with this education moment. So, anemia, taking control to feel better. This is one symptom of kidney disease that a lot of warriors don't think about or don't know about. So let me explain uh, what it is and how they deal with anemia in dialysis patients. Anemia is a very common condition for people with kidney disease. Thankfully, it can be controlled. Before we talk about how it's controlled, let's first take a look at anemia. So, if your blood is low in red blood cell, you have anemia. If you got low red blood cells, you have anemia. Red blood cells carry O2 or oxygen to tissues and organs throughout your body and enable them to use the energy from food. Without oxygen, without oxygen, these tissues and organs, particularly the heart and brain, may not do their jobs as well as they should. For this reason, if you have anemia, you may tire easily and look pale. Okay, let me go over this one more time. If your blood is low in red blood cells, you have anemia. Red blood cells carry oxygen or O2 to tissues and organs throughout your body and enable them to use the energy from food. Without oxygen, these tissues and organs, particularly the heart and brain, may not do their jobs as well as they should. For this reason, if you have anemia, you may tire easily and look pale. Anemia may also contribute to heart problems. Let me repeat that. Anemia may also contribute to heart problems. Okay. Anemia is common in people with kidney disease. Healthy kidneys produce a hormone called erythropoietin, okay, or EPO for short. So again, anemia is common. It's a common condition in people with kidney disease, okay? Healthy kidneys produce a hormone called erythropoietin, or EPO for short. And this is how it looks synthetically. This is how EPO looks synthetically. Let me show my people over on YouTube. This is how EPO looks synthetically. Okay. Now, healthy kidneys produce a hormone called erythropoietin or EPO, which stimulates the bone marrow to produce the proper amount, to produce the proper number of red blood cells needed to carry oxygen to vital organs. Okay, that's very important. Anemia is common in people with kidney disease. Healthy kidneys produce a hormone called erythropoietin, or EPO for short, which stimulates the bone marrow. The EPO stimulates the bone marrow so it can produce the proper number of blood cells needed to carry oxygen to vital organs. Okay, now here's where it gets tricky. Diseased kidneys, however, often don't make enough EPO. As a result, the bone marrow makes fewer red blood cells. Okay, so if you have kidney disease and you don't make enough erythropoietin, as a result, the bone marrow is not going to make enough red blood cells. Other common causes of anemia include loss of blood from hemodialysis. Again, listen to this. This is very important because you have a lot of warriors who lose their blood because of machine clots or some mistake that the technician or the nurse may have done, and they got to throw away all your blood. Maybe they got a little bit of air in it, okay? I don't know, but I've seen this happen a lot of times where warriors get their blood thrown away, and it's about a pint, about 2 cups of blood thrown away. And for someone who's already anemic, this can cause a problem. So as a result, okay, other common causes of anemia include loss of blood from hemodialysis and low levels of iron and folic acid. Iron plays a big role in this as well. That's why they give you a dose of iron or a course of iron. Normally, when they start an iron regimen, it's 1,000 milligrams, which is broken down over 10 treatments as 100 milligrams each treatment. That equals 1,000 milligrams. It completes the course of iron therapy. Then the physician may say, okay, after this course, we want to give you 50 milligrams every week or every other Wednesday or every other week, something like that, if you have iron deficiency. So these nutrients from food help young red blood cells make what we check hemoglobin or HGB, their main oxygen carrying protein. Again, these nutrients from food help young red blood cells make hemoglobin, which is HGB. That's where we check your hemoglobin twice a month at dialysis, their main oxygen carrying protein. Laboratory test, okay? A complete blood count or CBC. You may hear us say we got to draw a CBC, okay? A laboratory test performed on a sample of your blood includes, hey, Angela, thanks for tuning in. A laboratory test performed on a sample of your blood includes a determination of your hematocrit, the percentage of the blood that consists of red blood cells. The CBC also measures the amount of HEB in your blood. The range of normal hematocrit and HGB or hemoglobin in women who menstruate is slightly lower than for healthy men or healthy post-menopausal women. Again, the range of normal hematocrit and hemoglobin in women who menstruate is slightly lower than for healthy men or healthy postmenopausal women. That's important to know if you're on dialysis and you still menstruate. The HEB is usually about 1/3 the value of the hematocrit. When anemia begins, let me tell you when this symptom begins with people with kidney disease. Anemia may begin to develop in the early stages of kidney disease when you still had 20 to 50% of, uh, of your normal kidney function. This partial loss of kidney function is often called chronic renal insufficiency. Anemia tends to worsen as kidney disease progresses. Again, anemia tends to worsen as kidney disease progresses. End-stage kidney failure, the point at which dialysis or kidney transplantation becomes necessary, doesn't occur until you have only about, they have in this literature, 10% of your kidney function remaining. Nearly everyone with end-stage kidney failure has anemia. Pay close attention to that. Nearly everyone with end-stage kidney failure has anemia. So it's common. It's common. Diagnosis. Let's look at how they diagnose this. If you have lost at least half of normal kidney function, serum creatinine greater than 2 milligrams per deciliter, and have a low hematocrit, the most likely cause of anemia is decreased EPO production. Let me repeat that again. If you have lost at least half of normal kidney function, that is serum creatinine greater than 2 milligrams per deciliter, and have a low hematocrit, the most likely cause of this anemia is decrease in EPO production. So the National Kidney Foundation, Foundation's Dialysis Outcomes Quality Initiative, or DOQI, that's what they call it, recommends that doctors begin. So this is just a recommendation. This is not something that they have to do, but this is per NKF DOQI guidelines, or recommendations, I should say, that doctors begin a detailed evaluation of anemia in men and post-menopausal women on dialysis when a hematocrit value, check this out, when a hematocrit value falls below 37%. Okay. So when you lose at least half of your kidney function, you're going to these renal appointments to get your levels checked. If your levels or your hematocrit falls below 37%, then they should be recommending some type of epogen therapy. For women of childbearing age, evaluation should be given when the hematocrit falls below 33%. Okay, so anemia in men and postmenopausal women on dialysis when the hematocrit value falls below 37%. That's when the doctor should begin evaluation. For women of childbearing age, evaluation should begin when the hematocrit falls below 33%. The evaluation will include tests for iron deficiency and blood loss in the stool, okay? In the stool, to be certain there are no other reasons for the anemia. Let me see what Angela said over here on YouTube. I need y'all to come on YouTube as well. Subscribe to our YouTube channel, Urban Health Outreach Media. We're definitely going to be using that a lot more. Thank you, Angela Mason, for being the first one to come on this broadcast and post. So for that, Angela, if you send me your information in Messenger, your home address, I'm going to send you a t-shirt, Urban Kidney Alliance t-shirt from one of our shows, whichever we have left. I'm going to send you one since you was the first one to comment on our YouTube link during this broadcast. Thank you. So in Messenger on Facebook, when this broadcast finishes, send me your address. I'll get that shirt out there tomorrow morning. I'll go to the post office. Thanks again for your support. Okay, let's move on. So what's the treatment for anemia? Okay, there is a treatment. And I saw in one group, a caretaker was posting about her husband, how his hemoglobin was down in the nines and he was feeling weak and slow, tired. And the doctor, she was trying to reach to the doctor and he wasn't responding back. So I posted, what his, I think I asked what his hemoglobin level was and if he was receiving epogen, stuff like that, iron, because see, a lot of patients don't know, and it often get missed when they first get diagnosed. They go in the hospital and they may see it and give them transfusion. They may say your blood count is low, and you get a transfusion in the hospital. But after you leave the hospital, and if no one is telling you about anemia, what to watch out for, especially if you get diagnosed quickly. If you get diagnosed, thanks, Jeremy. I appreciate you, buddy. If you get diagnosed, Jeremy then came on our YouTube channel as well. I want to send you a shirt as well, Jeremy. I think we maybe got 3 more left. So I got you and Angela. Send me your address. Thanks a lot. But as I was saying, if you get diagnosed quickly, really fast, and not been to doctor's appointments, and you just found out and you're in the hospital, you're not going to know anything about anemia. No one's going to explain what we're doing here. If you're feeling weak and tired, you may think it's something else, but your blood count could be low. Your blood count could be low. Thank you, Carl. I appreciate you. So you got to know what to look for and what questions to ask once you first get diagnosed, because it could be anemia, it could be a low blood count, and it can save you a trip to the emergency room. But you don't want your blood count to go so low where your hemoglobin is down to 6, your hematocrit could be 21. No, most likely if new patients who get diagnosed with kidney disease are losing blood, most likely it's coming from your stools. And they give you this card called a GUAC test, where you get a stick and you take a sample of your stools and you smear it on the card, and then you put this activator on the back of the card, and it tells if you got heme or blood in your stools. And they ask you to bring the card back and they check it, but it's like blood occult. So this is really important. So let me tell you the treatment for this. If no other cause for EPO deficiency is found, it can be treated with a genetically engineered form of the hormone, which is usually injected, they say under the skin, but we give it to you subcutaneously. This is it. Okay, this is it right here. A lot of you may have seen this. Epogen, erythropoietin. It come in different strengths. You got, this is the strength for 4,000, but you got 10,000 unit strength. Let me turn this around. You got 10,000 units. This is 4. You got 2, 3, 4, and 10. And this is the 4,000 units. You can see the 4 on it, and you can see it here, the 4. Got you, Jeremy. There you go. So this is what you would get to replace the epogen or the erythropoietin that you're not producing from your kidneys. And so this is usually injected, they say under the skin 2 or 3 times a week, but we give it to you subcutaneously. So I guess you can call that under the skin. But if you're on dialysis and, oh, okay, wow, that's a lot, 35,000. I have one listener on my YouTube page saying they got it today, 35,000, or could be 3,500. But on dialysis, we give it to you in the lines. And normally we tell you, I'm giving you your epogen. And then we give it to you and give you a little saline so it makes sure that it gets to you. Hemodialysis patients who can't tolerate epogen shots may receive the hormone intravenously, just like I said, during treatment. But this method requires a larger, now check this out, guys. But this method requires a larger, more expensive dose and may not be as effective. So if you're not getting the shots in your arm and you getting it on the machine, it's saying that this method requires a larger, more expensive dose, and it may not even be effective. And then DOKI, which is the Dialysis Outcome Quality Initiative, recommend that patients treated with EPO therapy should achieve a target hemoglobin of 11 to 12. Okay, 11 to 12. That's where it should be. Now, when your hemoglobin starts to drop, okay, this is how they get slick on you. Okay, when it drops, they reduce the epogen amount. They cut it by 25%. So if you were getting 10,000 units and you achieve this level between 11 and 12, okay, some places have it at between 10 and 11. They want to shorten that guideline so they don't have to give you as much epogen. But when you get to 10, or I mean between 11 and 12, and you receive 10,000, they're going to cut that dose by 25%. So let me get my calculator out. That would be 10,000 units times 0.25. They will reduce that amount by 2,500. So you'll be getting, instead of 10,000, they'll cut your dose to 7,500. That's what you would be getting instead of the 10,000. So it's good to stay up on this, to know how much you're getting, what your range is, and everything. So let's talk about iron, because iron plays an important role in this as well. Many people, and see, you got a lot of patients who get this medicine, and what I'm teaching now, they don't know about it. They just know they get a shot because their blood is low, or they're anemic, or their iron is low, but they don't know the reasoning behind this. They don't know the reason why they're getting this. So that's why we try to explain it, so when you go back in, you can be fully equipped to talk about what's going on with your treatment with the nephrologist. Iron. Now check this out, because this is really important as well. Many people with kidney disease need both EPO and iron supplements to raise their hematocrit to satisfactory levels. If your iron levels are too low, now check this out, very important, very, very important. If your iron levels are too low, okay, EPO won't help. And you'll continue to experience the effects of anemia. So if you have an infection and iron is not going to work if you got an infection. So if you have an infection and your iron is low and they give you these EPO, it's not going to work. That's why you're going to feel crappy from the infection and you're going to feel crappy from anemia. That's why. But a lot of people don't know this concept or understand. If you have an infection, especially if it's a long-term infection, and your iron is low, because you got to check your iron levels to see if they still high when you got that infection, especially if you're getting antibiotics. And if your iron is low or too low, EPO will not help, because iron helps this transport this. So EPO won't help, and you'll continue to experience the effects of anemia. You may be able to take an iron pill, but you don't want to take iron pills because iron pills cause constipation. That's why they give you IV iron. But many studies show that iron pills don't work as well in people with kidney failure as iron giving intravenously. Again, many studies show that iron pills don't work as well in people with kidney failure as iron given intravenously. So they tell you to take iron pills, it's not going to work as better as it would given it intravenously. Iron is injected directly into an arm or into the tube that returns blood to your body during hemodialysis. Okay, a nurse or doctor, now check this out. If you never received iron before, okay, this is how it's going to work. A nurse or doctor will give you a test dose. Normally it's the charge nurse or the nurse who's taking care of you or passing meds for their treatment. And what happens, they would give you a test dose, and because a very small number, they say less than 1% have a reaction to iron. So that's why we give you a test dose. Normally it's 25 milligrams. And we're supposed to just put it in a little at a time. You don't slam it in. They give it to you a little over time, okay? And if you have a reaction, they should have medicine there just in case. Normally, if you have a reaction, they got Benadryl there to counteract that. So they say less than 1% have a bad reaction to iron injections. If you begin to wheeze, now if you get iron, this is important. If you get an iron test dose, if you begin to wheeze or have trouble breathing, your healthcare provider can administer, and they have here epinephrine. But I want to tell you, they're not going to give you no epinephrine for this iron reaction. They want to give you Benadryl, okay, or corticosteroids to counter reaction. Even though the risk is small, you'll be asked, now check this out, you'll be asked to sign a form stating that you understand the possible reaction that you have, that you agree to have the treatment. Now, I never asked nobody to sign no consent form for no iron therapy. All right. Talk with your healthcare provider if you have any questions. In addition to measuring your hematocrit and hemoglobin, your test will also include 2 measurements to show whether you have enough iron. That is your ferritin level, which indicates the amount of iron stored, okay, in your body. This is the amount of iron stored in your body. That's the ferritin level. According to Doki guidelines, your ferritin score should be no less than 100 micrograms per liter and no more than 800 micrograms per liter. Okay, so there's a range. They said no less than 100 and no more than 800. Your TSAT, which stands for transferrin saturation, is a score that indicates how much iron is available to make red blood cells. Now, if your TSATs are low, okay, like lower than 20, you're not going to have nothing to make red blood cells. So the guideline calls for TSAT scores greater than, well, between 20 and 50%. They want your TSATs or your transferrin saturation between 20 and 50%. Okay, other cause of anemia. In addition to EPO and iron, a few people may also need vitamin B12 and folic acid supplements. Okay, if EPO, iron, and folic acid all fail, your doctor should look for other causes such as sickle cell disease or an inflammatory problem. At one time, aluminum poisoning contributed to anemia in people with kidney failure because many phosphate binders used to treat bone disease caused by kidney failure were acids that contain aluminum. But aluminum-free alternatives are now widely available. Be sure your phosphate binder and your other drugs are free of aluminum. Okay? Anemia keeps many people with kidney disease from feeling their best, but EPO treatments help most patients raise their hemoglobin, feel better, live longer, and have more energy. So now I was reading from information from the National Institute of Health. National Institute of Health has this information widely available, but a lot of warriors don't know about it. Okay, let me jump in. I don't have too much time. Warriors Quest is coming up, but let me jump into understanding AKI. And you may ask, what is AKI? Okay, AKI is acute kidney injury. So a diagnosis of acute kidney injury can be overwhelming. An acute kidney injury means your kidney shut down temporarily. It's not a chronic condition. It's an acute condition that can last a day to whenever it want to resolve itself. So let me tell you what it is. AKI happens when your kidneys are suddenly, so I said suddenly damaged to a point where they aren't working right. The body isn't filtering out toxins like normal and needs a little help. Okay. Now, dialysis treatment helps to do the important jobs that the kidneys can't temporarily do. Some people are able to recover from AKI. That's why you may hear some people say, I had to start dialysis because my kidney shut down temporarily. And I've seen many patients go on dialysis, and after 2 or 3 weeks, the doctor takes them off. You know, they're doing 24-hour creatinine clearance every week to monitor that, but they just need the kidneys need a little bit more push to wake up. So it says some people are able to recover from AKI. Many do not recover and need to continue dialysis treatment or get a kidney transplant. AKI is also known as acute renal failure, or ARF, acute renal failure, and AKF, acute kidney failure. Okay. Staying healthy if you have AKF or ARF. When starting treatment for AKI, there are some important things to remember to stay healthy. Pay attention to your urine. And that's what I was saying. Pay attention to your urine. The amount you are urinating can mean changes in your kidneys. That's what I'm saying. They normally do 24-hour creatinine cleanse every week on patients. Talk to your nurse about how to keep track of how much you urinate. They give you these containers with the measuring on the sides. Always let your nurse, always let your nurse and care team know if there are any changes in your urine. That means if you're doing too much or you're doing too less. 2, take special care of your central venous catheter. Most likely, if you got acute kidney injury, you're going to have a catheter. So make sure you take watch of that while you're dealing with this. CVCs have a high risk for dangerous blood infections. Keep your catheter clean and dry. Let your care team know if your bandage gets wet or dirty, and they'll change it. They're supposed to change that each treatment. Don't let them tell you otherwise. Each treatment, your dressing gets changed. So with that being said, signs of infection include fever, chills, and nausea. Let your care team know right away if you are feeling any new symptoms. Okay, definitely. Excuse me. Okay, again, this is a continuation of staying healthy with AKI. Replace your catheter. The catheter in your chest is temporary. It's important to prepare for a safer way to connect to dialysis going forward. A permanent access like a fistula or grab or a PD catheter gives you a safer way to do dialysis in the future. That's only if you know you're going to end stage or your kidneys don't recover. But if you got acute kidney injury and they see progression of your kidney functioning coming back, then you don't have to get it changed. Okay. Excuse me. Talk to your care team about treatment options and steps for getting a permanent access. Talk to your care team about all the medications you are taking, both prescription and over the counter. Some medications like ibuprofen can cause more damage to your kidneys. Okay, now check this out. If you're taking Advil, ibuprofens, Motrin, all these pain medications over the counter, if you got acute kidney injury or your kidney functions decrease, these are going to take it all the way down. So I encourage you, do not take any over the counter. I mean, Tylenol is okay, but Motrin, NSAIDs, ibuprofen, all that stuff, Advil, they could do more harm than good. Okay. And most of y'all know the care team, the facility administrator, the doctor, the nurse, patient care techs, social worker, dietitian, and administrative assistant. And one more thing I want to go over, the last but not least, keeping you safe. Keeping you safe. All right. Safety is, as a lot of these big organizations say, their number one priority. So here are a few ways that they try to keep you safe. Every new technician and nurse gets 10 weeks of clinical training at, you fill in the blanks. So whatever, whatever you want, company you want to fill in the blanks with, that's what it is. Every new blank technician and nurse gets 10 weeks, okay, of clinical training at, you fill in the blanks. This is on top of their education and prior clinical training. But look, if these places hire people that don't have education and prior clinical training, as we was talking about in the other shows, people coming from Walmart or a fast food place, that's not prior clinical training. That's what I was talking about. They got it in their literature. They say this is on top of their education and prior clinical training. What prior clinical training if you came from a fast food restaurant or Marshall's? Okay, they learn about how to insert needles. Now check this out. This is the training that this large company says that they do. How to insert needles with little pain, how to run dialysis machines safely, how to clean and care for your access, safely handling used medical supplies, safely handling medical emergencies, safely evacuating the clinic in case of natural disaster or emergency, and paying close attention to patient needs. Give me a freaking break. Paying close attention to patients' needs when you got most technicians and nurses sitting at the desk like this on their cell phone, looking at their cell phone. You know what I'm saying? They got their cell phone looking at it, and you on the machine, the alarm is going off, and they are looking at their phones while you hearing this beep, okay? Give me a break, all right? Paying close attention to patients' needs. Okay, a big part of keeping you safe is controlling infections. Here are steps that they say they take to stop the spread of germs and infection. Hand washing. This company says our staff washes their hands after direct contact with a patient or dialysis machine, after contact with any body or treatment fluid, before and after touching clean areas such as supplies, before putting on and after removing gloves, when entering and exit the treatment floor. Give me a break. How many technicians you seen leave the treatment floor and wash their hands, or when they come back, they wash their hands once they get back to the floor? You see them come through the door, grab their lab coat, put it on, and come over to you and say, how you doing? Man, give me a break with this shit that they putting this propaganda on here. I'm starting to get pissed now because half of this shit, a lot of the technicians and nurses don't do. Okay, glove usage. Staff wear gloves when giving patient care, touching the dialysis machine, supplies, or equipment. I've seen many technicians touch the machine with no gloves on to reset the alarms. They expect contact with body or treatment fluids. Staff remove and change gloves when gloves are dirty with body or treatment fluids. Switching between patient contact or different dialysis machine. Come on, man, give me a freaking break. Switching between patient's contact or different dialysis machine and washing or sanitizing hands. Chair sanitation. Staff sanitize chairs and TVs between every treatment. Get comfortable. Your chair is clean. Give me a freaking break. A lot of staff do not clean that TV. And I highly recommend you, when you go to dialysis, ask for a glove and a bleach rag and wipe down that TV and that arm that TV is on, because you got other patients that were there before you touching it. Okay? I'm going to tell you, a lot of staff don't clean that TV, not between treatments. No, maybe at the end of the day, but not between treatments. I kid you not. So make sure you wipe your television and arm down and everything. And so they say, they encourage you to speak with your FA. So you know what company I'm talking about, say FA, if you have any questions or concern about your safety during treatment. Guys, absolutely. Bring your own. Let me put that up, Jeremy. Boom. Boom. Do like this man does. JP. He bring his own Santa wipes. Boom. You bring that, you good. You good. You ain't got to ask the staff for any bleach rags. So, guys, I got to go. I got 10 minutes before the Warriors Quest. I thank you for watching this special broadcast of Kidney Disease Education Moment, Anemia Taking Control to Feel Better. We hope you tune in for more special education moments as we bring them to you. Thank you, guys. Stay tuned for Warriors Quest with Jared A. Brown in about 10 minutes right here on Urban Health Outreach Media. Thank you guys for watching on YouTube. Thank you for watching on B Live. See, if you would have came on YouTube like Angie and JP, you could have got a free shirt sent to you. We don't have many, but the little itty bitty ones I have, I'm going to send one to Angela Mason and Jeremy Peruco. And see, this is what the donations go to for Urban Health Outreach, to do stuff like this and to give back. So until next time, guys, thanks for watching. I appreciate you listening. I hope this broadcast at least helps someone. And until next time, stay blessed and encouraged. Thanks again for watching. Peace, guys. YouTube, thanks for watching this amazing show. Again, I'd like to thank Kidney Girl. Oh, I'm going to get you one too, Kidney Girl 91, Angela Mason, and Jeremy Peruco. Thanks for watching our YouTube broadcast. I will send you a t-shirt in the mail. Until next time, stay blessed and encouraged. Peace.